Professor Amr asked me to talk about introduction of uveitis. In fact, we need some important basic knowledge in order to enter the uveitis world. Interestingly, the earliest reported documentation of uveitis dates back to the ancient Egyptians. The reports found in the Edwin Smith surgical papyrus, and this papyrus is now housed in the New York Academy of Medicine. So the ancient Egyptians started the description of uveitis and they started diagnose and treat uveitis. So first, we need to know what is uveitis. Uveitis is inflammation of the uvea, which is the middle coat of the eye. As we all know, the word uvea came from the Latin word uva, which means grape. It is in Arabic العنبية, التهاب العنبية, because in cross section the uvea looks like a grape. So that's why it is called uvea and its inflammation is called uveitis. Anatomy of the uvea. Of course, all of you are familiar with the anatomy of the uvea, but you have to pay attention to the importance of the anatomy and the physiology also of the uvea. As we all know, the uvea starts with this beautiful organ, which is the iris, which is the colored anterior part of the uvea. The second part is the ciliary body, which is a ring-shaped muscle. The third part, of course, is the thin choroid posteriorly. Have you thought about uvea as an organ which has a function? In fact, the uvea has important function. As you can see, the iris controls the amount of light entering the eye. And the ciliary body is very important for accommodation. And the elderly people like me knows how the ciliary body is important. In fact, the choroid plays an important role in the nourishing the retina. So the uvea has a very important function. In terms of the epidemiology, unfortunately, uveitis affects people in the working population, the middle-aged population. So this has a high socioeconomic impact. So authorities, health authorities, and doctors should pay attention to this important disease because it affects the working population. The important question, when one of my colleagues refer a patient to me, he of course diagnoses uveitis, but he needs to know what is the cause. I used to tell my patients that we have at least 150 diseases that are known to be associated with uveitis and intraocular inflammation, and underline the word known. We still have unknown causes. So at least we have 150 disorders that are known to be associated with intraocular inflammation, and it is our mission as uveitis specialists to find out what is the underlying etiology. So we have a long journey to reach the diagnosis. So reaching the diagnosis depends on several factors. First, we have to know and to categorize the etiology of uveitis. Traditionally, we used to tell the patients and tell the doctors that we have two important subtypes, and they are totally different. Either infectious uveitis or non-infectious uveitis. Infectious uveitis can be caused by bacteria, viruses, fungi, parasites. Non-infectious, which is immune-mediated disease, they are totally different, and you cannot treat immune-mediated uveitis with antibiotics. And if you treat infectious uveitis with immune modulators, you may harm the patient or even kill him. And between them, we have the masquerades. So our duty is to find out what is the underlying etiology of uveitis. How can we reach this? If you check the textbooks, you find different diagnostic algorithms like naming, meshing, office testing, blah, blah, blah. I really myself don't like this. I like to use the simple medicine, what we have learned in the School of Medicine. in every aspect of medicine, if you go back to your faculty teaching, you depend on history, clinical examination, and investigation. That's it. This is what we do in all parts of medicine and in other subspecialties of ophthalmology. So you have to take a very good history. You have to perform a very meticulous clinical examination, and you have to order the appropriate investigations. We will go over this one by one. Regarding history, I always tell my younger colleagues and my patients that I stay more than 20 to 30 minutes with each patient, particularly in the first visit, in taking history. And all good doctors should take very good history and detailed history. And in fact, I can tell you that I can reach up to 70 to 80% of the diagnosis just from taking a detailed history. Always remember that we are looking for a cause among 150 known causes. So every piece of knowledge and the history counts. So you have to pay attention to every word the patient tells you in terms of the complaint and in the review of systems. We have two types of taking history. We can use a pre-designed uveitis questionnaires, and this is easier for the beginners. And we can have the direct interview, and this is the way I like very much. Because, as you know, when you directly interview the patient, you can learn, you can hear the patient, you can know what is his concerns, what is his problems. You can dig deeper in any problem. So if he has, for example, abdominal problem, you can ask him more. In the pre-designed questionnaire, you don't have this opportunity. So I myself prefer the direct interview and asking the patient directly. And there are some important things that can be done. Unfortunately, yes, good, thank you. There was something drawn, but it is now disappeared. So, as we know, it's my preference to have a direct questionnaire. Now, going to the clinical evaluation. As we know, and always still also telling my young colleagues and residents, if you need to know and to see all signs in ophthalmology, you have to attend the uveitis clinic, because we have signs starting from the eyelids, the conjunctiva, the cornea, the anterior chamber, the lens, the vitreous, the retina, the choroid. So in the uveitis clinic, you can see all types of clinical signs. And as we know, the clinical signs are variable. So how can we describe this clinical signs? As we mentioned, there are myriads of clinical signs. That's why this paper was a milestone in the field of uveitis, which is the standardization of uveitis nomenclature for reporting the clinical data. The aim of this paper was to have a diagnostic terminology and to have inflammation grading scheme and to define the outcome measures. Because as we know, every subspecialty in ophthalmology has its own terminology. For example, the squint people have their terminology, have the muscle movement, the gaze directions. The refractive people like Professor Amr have the pentacams, and they have the wave front guided, and this all stuff. So in uveitis also we have our own terminology. So the aim of the Sun working group is to standardize these outcome measures and the diagnostic terminology. For the first part, which is the classification of uveitis, for me it is the very important first step to be able to diagnose uveitis, which is the anatomical classification of uveitis. This should be the starting point in your workup of uveitis. As we all know, we have anterior uveitis intermediate uveitis, posterior uveitis, and panuveitis. As we all know, anterior uveitis, when you have inflammation mainly affecting the anterior chamber, as you can see here, the cells mainly in the anterior chamber, and you may have some spillover cells in the anterior vitreous, but the main site of inflammation is the iris and the ciliary body. So in this case, we call it anterior uveitis. Regarding the second type, which is the intermediate uveitis. The intermediate uveitis, when inflammation affects mainly the peripheral retina and the vitreous, as you can see here, the main site of inflammation in the vitreous, and there are some spillover cells in the anterior chamber. Posterior uveitis, which includes inflammation of the posterior part of the uvea. And here I have to stress a very important piece of knowledge. Posterior uveitis means either retinitis or choroiditis. Okay? Either retinitis or choroiditis. Because I used to see some reports from my colleagues, some of my colleagues, when they say macular edema or when they see optic disc edema, they call it posterior uveitis. No, posterior uveitis by definition is either retinitis or choroiditis or retinochoroiditis or chorioretinitis. This is very important to put right classification. And the last one is the panuveitis, when you have inflammation involving all part of the uvea. So the first part to reach the diagnosis is to have a good anatomical classification. Going to the next step, which is the inflammation grading. As you can see here, these two pictures, these two patients have anterior uveitis. Do you think the patient on the left has the same grade of inflammation like the patient on the right? Of course, no, even from just having a look. So how to grade this and to put a standardized method to grade this inflammation? And here comes the Sun classification of grading the cells and grading the flare. Of course, it is found in the paper and I will not read it out, but it is very important to have a grading system for the cells and the flare. Why it is important? Because by this you determine the severity of the disease, and also very important in the follow-up of the patient. If you have a patient with 4+ cells and 4+ flare and you treated your patient and he comes back with inflammation of 2+ cells, so this means improvement. So this is very important to have a grading system to help you to determine whether your patient improved or not. The outcome measures, this is also very important in terms of the onset, duration, and course. Coming to the important and somewhat confusing part of the uveitis workup, and this is actually a very common question. I used to have calls from my colleagues. Please, doctor, I have a patient with anterior uveitis. So what types of investigations would you like to order to the patient? In fact, there are no standardized battery of tests that you can order to all patients of uveitis. You can't have a pre-designed paper to order for all patients of uveitis. And this makes sense because you may have a patient with anterior uveitis, like in the photo in the upper left. You can have a patient with snow pools. You can have a patient with posterior uveitis, like the one in the bottom right. So are you going to investigate all these patients by the same set of investigations? Of course, no. There is no standardized battery. So the task is not that easy. The second question also, some of our colleagues ask, are we going to investigate all patients with uveitis? I will tell you the traditional teaching and tell you what is new or what is in practice. Traditionally, you are justified not to write investigations or to ask for investigations in patients with single attack of mild unilateral acute anterior uveitis. But pay attention, any disturbance of this, you have to investigate. So if it is second attack, for example, you have to investigate. If the attack is moderate or severe, you have to investigate. If it is bilateral, you have to investigate. If it is chronic, you have to investigate. If it is anything other than anterior, you have to investigate. So if you have these 5 criteria, single, mild, unilateral, acute, anterior uveitis, some authorities say that you are justified not to order investigations. Okay? The second situation, when you have a condition that is diagnosed purely on clinical backgrounds like Fox heterochromic iridocyclitis, when you have heterochromia, for example, so it is a clinical diagnosis. The third scenario, when you have a systemic disease compatible with uveitis. For example, you have a patient referred to you from a rheumatology colleague saying that this patient suffers from Behçet's disease. So in this case, some authorities do not order lab tests. But in fact, I will tell you the controversies of all of these. Generally speaking, for example, in the Western literature, there is no patient with uveitis that cannot be investigated, at least for the syphilis serology. Syphilis is ordered for all patients of uveitis in the Western population because syphilis is common and can mimic any type of uveitis, even the first category, which is single mild unilateral acute anterior uveitis. So if you don't test the patient with syphilis and he has syphilis, and you not treat, the patient may go to tertiary syphilis and may have severe complications and eventually die. Someone may tell syphilis is not common in Egypt. I agree, I totally agree. But we are seeing more increasing number of syphilis here in Egypt. We are testing people with syphilis and they have it. On the other hand, the comparable to syphilis in our area is the TB. We have to order tuberculin skin test or quantiferon for all our patients with uveitis. This is what I am doing in my practice because tuberculosis also is a great mimicker and can cause anything, any type, any anatomical location. So you have to test. The second, which is the Fox heterochromic iridocyclitis, as I mentioned before. Fox was thought to be earlier as idiopathic disease, but in fact now it is becoming recognized as being a viral disease. Okay? Cytomegalovirus is thought to be the cause in our region, and rubella is thought to be the cause in Europe, and the same also for Posner-Schlossman and the chromatocyclitic crisis. They were thought to be idiopathic, but now they are recognized as being of viral etiology. So it is not idiopathic anymore. The third scenario is the worst, and I have an experience myself. Some of my colleagues, a rheumatology colleague, sent me a patient with Behçet's disease. He was diagnosed with Behçet's, and he was right because the patient complained of oral ulcers, genital ulcers, and panuveitis. And the patient was not responding to systemic therapy. And his rheumatologist referred him to me to prescribe biologic therapy for him, to approve biologic therapy for him. When I examined the patient, I incidentally saw his hands and legs, and he had palmar and solar rash typical for syphilis. And I asked for syphilis serology and HIV, and he turned out to be syphilis positive and HIV positive. So if I give this patient biologic therapy, he will be deteriorated and may also die. So please also, if you have a patient that has a diagnosis or an earlier diagnosis and he is not responding to therapy, you have to investigate your patient. At the end, you are a clinician and we are helping each other. We are helping the rheumatologist and the rheumatologists are helping us. So not to be confused, and we will come to this, I think all patients with uveitis should be investigated at least a core of tests that I will mention now. So this is what I mentioned: Fox heterochromic iridocyclitis. It is of course an internet picture. In reality, the clinical situations, it is not clear like this. We have cases of heterochromia, but it is not like this. But as I mentioned before, it is now being recognized as being a viral etiology. Behçet's disease, as I told you, I have a patient like this who came to me to prescribe biologics, but he turned out to be syphilis. So, what are the types of investigations? We have, of course, diagnostic tests that will help us to identify the underlying etiology of the uveitis, and this is a very important step. And we have the tests to assess the response to therapy, like the non-specific tests, like the ESR and CRP. And we have tests for monitoring side effects of therapy. This is very important because we are using dangerous medications, immunomodulatory therapy. So we have to monitor the liver functions and the renal functions of our patients, in addition to some other important tests. What are the types of investigations that are available at our hands to use in our patients? We have the serologic tests, we have the imaging techniques, the tissue biopsy, and the skin test. These are the old types of the tests. So, what test should I order? This is a very important question I ask myself when I see a patient with uveitis. So, before answering this question, there are some important questions that should be answered before this. Very important to ask myself, why do I order this test? Because sometimes we, as uveitis specialists, order many tests. And because of the financial burden, some patients argue why you are ordering all these tests. In fact, I order every test for a reason. I never order test without waiting for a specific finding related to this disease. So please, before you order any test, ask yourself, why do I order this test? Why I order quantiferon? Why I order ACE, angiotensin converting enzyme, in this particular patient? And the second question, will this affect my diagnosis? Does this will make any change in my diagnostic plan? This is a very important question to ask yourself. The second thing to know is, before asking, it will be good if you know any piece of information regarding this: the sensitivity of the test, the specificity of the test, and the pretest likelihood. I know this looks like a very tough academic teaching, but we have to know a piece of information about this. For example, the sensitivity of the test. If you have a test with a higher sensitivity, like 90%, this means that this test is reliable. For example, if a test for Lyme disease is 90% sensitive, so if you have a positive result, it is 90% will be true, and you have a very low false negative results. The specificity of the test, on the other hand, when it is also higher, like 90%, so this means that this test is specific to Lyme and rarely positive in other diseases. But unfortunately, the sensitivity and the specificity of most of the tests are not known, but it will be good if you know some information about the sensitivity and the specificity of the test that you are using. The third part, which is very important and applicable to us here in Egypt, which is the pre-test likelihood of a disease. And this depends on the patient history, physical examination, and incidence of a particular disease in this area. For example, the syphilis, which I have mentioned. In Europe and United States, they are testing for syphilis for all patients. It is not applicable here in Egypt. I don't have to order syphilis for all our patients. We still have some morals in our community. We still have not that high incidence. So it is not reasonable to have syphilis serology for all patients. But on the other hand, Egypt is nearly endemic for TB. So I have to order tuberculosis for all of our patients. So this is what we call the pre-test likelihood of the disease. Another example, the HLB27 is very common in males in unilateral cases. So if I have a female, old female with bilateral, so the pre-test likelihood is low. So you got it? You have to consider all these before ordering your lab tests. So, as mentioned before, we don't have a standardized battery of tests, but we have to have a tailored approach. We have to tailor the laboratory tests according to the patient age, gender, anatomical location, pathological presentation of the uveitis. So we don't have a standardized battery, but we have a subset of core tests. This is the core test I order for all my patients with uveitis, whatever the etiology. I order CBC differential, ESR with or without CRB, syphilis serology or tuberculosis, angiotensin converting enzyme, urine analysis, renal function tests, liver function tests, and chest radiographs. And I will tell you just a brief hint about every of these investigations. The CBC, which is the complete blood count, this is the most common test performed worldwide in medicine in general. And it is very valuable in uveitis. Why? For example, for the parasitic diseases, you can have eosinophilia. The eosinophils are high. In the other diseases with connective tissue diseases, you may have anemia, for example. And in following up patients taking immunomodulatory therapy, if you have decrease in the white blood cells, you should stop the medication or switch to other. So this is very important. The ESR and CRB, they are non-specific. They are non-specific biomarkers, but it tells you about the status of the inflammation. If they were high and then become low, this means that the inflammation is controlled. Coming to syphilis and TB, I mentioned this before. So here in Egypt or in our region and the Middle East, TB has a priority because we are discovering more and more cases of TB in our region. ACE, angiotensin converting enzyme, is very important because it is very helpful in the diagnosis of sarcoidosis. But we have to pay attention to two important points. ACE is normally high in children. So if you have a patient with a child patient with uveitis and you had an elevated ACE, you should put it in the whole picture because sometimes children normally have high ACE. On the other hand, elderly patients with hypertension taking angiotensin converting enzyme inhibitors, taking ACE inhibitors, will have lower ACE. They may have sarcoidosis and higher ACE, but the medication brings them down. Urine analysis is very simple and cheap test, but for me it is very important, particularly for the proteinuria. The first thing I look at in urine is the proteins. If you have protein in urine, this is a very dangerous situation. This may mean that the patient has a connective tissue disease with kidney affection. So this is very important to rule out systemic vasculitis in this patient. Renal function tests, this is very important for the therapy. The same also for liver function tests. You have to have good renal functions and liver functions before starting your patient with immunomodulatory therapy. Chest radiographs, I order chest X-ray or CT chest in all my patients. Why? Both of them are cheap, either chest X-ray or CT chest, but they answer very important questions. We have two important diseases we mentioned that we have to rule out, which are the TB and the sarcoidosis. In addition, also, it can show you Wagner's granulomatosis, although it is rare, but it is very important. So chest X-ray is an important part of my workup for patients with uveitis. Now, after putting this core test We will tailor the test according to the anatomical diagnosis that we mentioned before and also according to the pathological diagnosis. As we all know, uveitis could be granulomatous or non-granulomatous. So in cases of non-granulomatous uveitis, as I mentioned, I will order the core tests I showed to you in addition to these. HLB27, this is very important, particularly in males, middle age, and if it is unilateral. Viruses are very important causes also. In fact, when I see a patient with unilateral uveitis, whether male or female, I always think of these two entities, either B27 disease or the viral etiology. ANA is very important. Anti-nuclear antibody is very important in children, particularly those with GIA, juvenile idiopathic arthritis. So if I have a patient with granulomatous uveitis, and if I have granulomatous uveitis, I become happy because this narrows my differential diagnosis. The common causes of granulomatous uveitis include tuberculosis, sarcoidosis, Vogt-Koyanagi-Harada disease, multiple sclerosis. That's why I emphasize here on chest X-ray, tuberculin test, and serum ACE levels. Patients also with intermediate uveitis have narrow differential diagnosis. So in addition to the core tests, I pay attention to the chest X-ray because sarcoidosis and TB are important causes of intermediate uveitis. Here we put something new, which is MRI of the brain. Why we put this here? Because intermediate uveitis is associated with MS, multiple sclerosis, particularly in middle-aged females. And we have several cases of multiple sclerosis that we were the first to diagnose based on the presentation of intermediate uveitis. And when we ordered the tests, everything were normal, and the MRI of the brain showed the typical demyelinating patches that consistent with MS. Of course, these demyelinating patches do not diagnose MS by themselves, but we refer the patients to a neurologist who confirms or denies the diagnosis of MS. ASCA, which is the anti-Saccharomyces antibodies, this is very important to diagnose inflammatory bowel disease, which is also associated with intermediate uveitis. Stool calprotectin also important in the diagnosis of intermediate uveitis, and of course we know the BBD and the ACE. Going to the posterior uveitis, fortunately, most of the cases of posterior uveitis are infectious, and in fact, they are the most devastating type of uveitis. And the most common cause of infectious uveitis in Egypt and in all parts of the world is toxoplasmosis. Okay, so we have toxoplasmosis, toxocariasis, Bartonella, TB, and viruses. So as you can see here, sorry, the majority of the causes are infectious diseases. So my suggested approach, as I told you, this is for you just if you would like to follow this scheme. These are the tests that you should order, at least you should order for all patients with uveitis, like core tests, and then you add the necessary tests according to the anatomical and the pathological type of the uveitis. Just now, I have just still like 3 or 4 slides. I will not go into details of the treatment of uveitis. We may have this in another lecture, inshallah, if Dr. Amr gives us another opportunity to discuss this in details. Treatment of uveitis also is difficult like the diagnosis, and we have plenty of therapeutic modalities, but interestingly, in the past, they used to use fever therapy to treat patients with uveitis, and this is something that was interesting because they used to inject patients with animal milk or typhoid antigen to increase the body temperature above 40, and this leads to endogenous release of steroids, and you all know steroids can help treat uveitis. And the milestone of the treating uveitis, in fact, was in 1950 with the discovery of the corticosteroids. Here is a very important point because patients and doctors are afraid of using steroids. And we always tell steroids are very important medications if they are used judiciously. They can save your sight and can save your life. And these are very important. And I myself cannot imagine how will be our lives without steroids. Steroids are very important. They are very helpful. So we treat uveitis by the term immunomodulation, and the immunomodulatory therapy entails the use of medications that modulate the immune system. And our goal of therapy in uveitis is to have control of intraocular inflammation and reduce the complications of inflammation and reduce secondary visual loss. And while doing this, we are trying to balance the risk and benefit of treatment. The treatment modalities that we have at our hands include steroids, as I mentioned. We have conventional systemic immunosuppressive therapy like methotrexate, mycophenolate mofetil, azathioprine, and now we have the recent era of biologic therapy, and I had the pleasure and opportunity to discuss this with Dr. Amr Munir in a very nice podcast in Arabic. So I hope in the future, inshallah, we will have another opportunity to talk about the treatment modalities of uveitis broadly. And finally, I would like to thank you for your attendance, and I hope you enjoyed this lecture. Thank you very much.
Thank you, Dr. Samir, for your nice and interesting lecture about this complicated and difficult topic, which is uveitis.
دكتور سمير بعد اذن حضرتك، هو بس في يعني الحالات بالنسبه لجرانيوماتيس يوفيايتس، لو كان الحاله مثلا اولد، يعني مش شرط اكيوت، فالاولد اللي هو ليه بقى الكيبيز تبقى بيجمنتد وكده، الحالات دي برضو لازم تتبعت انفستيجيشن بتاعه الجرانيوماتيس يوفيايتس عادي، ولا تعتبر يعني الابروش بتاعها تبقى ازاي؟
Okay, thank you. So I just thank you for this very important question. I will just recap the question because we may have some non-Arabic speaker audience. So our colleague asked a very important question. He asked, if you have an old granulomatous KP, so are you going to investigate the patient? The ultimate answer is yes. Particularly if the patient was not diagnosed previously or in advanced stage. So if I am seeing a patient, for example, now a female patient with granulomatous uveitis, and she doesn't have cells in the anterior chamber and her vision is poor, I have to find out the underlying etiology, because I have to prevent the recurrence, because this patient may be in a period of relapse and may have a recurrence again. This patient may have underlying systemic disease. So I have to find out if there is any underlying systemic disease or not, and on the same time to prevent further damage to the eye. So I have to find out the underlying etiology. So in continuation with this, Dr. Amr, I have seen the written questions here. Some of our colleagues asked about the differences between granulomatous and non-granulomatous uveitis, and how can this help in the differential diagnosis. So as I mentioned, we have two pathological types of uveitis, granulomatous and the non-granulomatous. The most common is the non-granulomatous, of course, when you have a fine KPs on the cornea, but in the granulomatous KPs, you have large KPs, from medium to large KPs. The presence of granulomatous uveitis and the granulomas narrows the differential diagnosis. So again, when I see a case of granulomatous uveitis, whatever the gender and the age, I think of tuberculosis, sarcoidosis, Vogt-Koyanagi-Harada disease, multiple sclerosis, sometimes Wagner's, sometimes sympathetic ophthalmia. These are the most common causes of granulomatous uveitis.
السلام عليكم دكتور سمير.
عليكم السلام ورحمة الله وبركاته. Can you introduce yourself please, دكتور?
أنا دكتور منى وحيد. شكرا جزيلا لحضرتك على المحاضرة. شكرا.
أهلا بحضرتك، أهلا وسهلا.
تسلم. أنا بس عايزة أسأل لو في الانيشال فيزيت لأي بيشنت معاها anterior uveitis usually مش هقدر أحكم هل هي isolated anterior uveitis ولا معاها حاجة تانية. ف if it a recurrent attack للبيشنت ده وأنا هطلب investigations, التوبيكال تريتمنت اللي ممكن أكتبه للعيان ده إيه بالظبط, وهل السايكلوبلاجيك medications contra indicated في حالات معينة؟
Okay, again, allow me to recap the question in English, please. So our colleague Dr. Mona asked very important questions about if the patient has, for example, an attack of uveitis and maybe recurrent, and we don't know if there is any other inflammation in the eye or not. This is your responsibility. You have to examine your patient carefully. You have to examine both eyes. You have to dilate your patient, and you have a look at the vitreous, and you have a careful look at the retina in order to properly classify anatomically the uveitis. So you have to carefully examine all parts of the eye, and you have to examine both eyes, even the patient complains only of one eye. Regarding the treatment, we are fortunate that topical treatment don't differ from different types of uveitis. But the very important thing, if you are planning to send your patient to a uveitis specialist, you have to document your findings, because the types of the key beads and cells are very important. And one of the problems that we face when we are treating our patients with uveitis, if you started or any of our colleagues started the treatment, because this will alter the clinical picture. For example, if it is granulomatous and you start the treatment, this will turn it to non-granulomatous. The treatment may decrease the level of inflammation, and this may hide some of the signs. Of course, I'm not telling you not to treat the patient, but if you are going to start a treatment, you have to have a very good documentation of your findings. For example, you should write the type of the key beads. It is granulomatous, non-granulomatous, the location, is it diffuse or stellate, the anterior chamber cells, the grade of the cells, and the type of the cells, if they are large or small. I think you understand me now. Regarding your last question about the use of cycloplegics, we use cycloplegics when we have fibrin in the anterior chamber to prevent posterior synechiae. I myself don't prescribe cycloplegics for all patients. When I see fibrin or when I see excessive flare, because you prescribe cycloplegics to prevent posterior synechiae and to release the pain of the patient. So if you have the fibrin and the patient is complaining of severe pain and photophobia, so in this case you are justified to use the cycloplegic medication. When they are contraindicated only, of course, in narrow angle. If you are examining the patient, you are suspecting narrow angle and shallow anterior chamber, so you have to be cautious. I hope I answered all your questions.
Dr. Samir, I want to ask a group of questions of mine.
Yes, please.
The first one of them is how to differentiate between viral anterior uveitis and autoimmune anterior uveitis, because we face these cases many times. You face a patient with bilateral uveitis, and you want to give him steroid therapy, topical and systemic, and start treatment with him, but you afraid. What about if it was viral uveitis, which is common in?
Okay, Dr. Amr, really a very important question, in fact, and we to be careful in the difference. When, as I told you, Dr. Amr, and in my talk, when I see a patient with unilateral uveitis, not bilateral, when it is unilateral, I think of either B27 related disease or viral etiology. Fortunately, we have criteria for the viral uveitis. First, I will suspect viral if it is unilateral uveitis, with diffuse stellate cratic precipitates, with iris changes and elevated intraocular pressure. If I have all these four criteria, it is most likely viral. Again, if it is unilateral, with diffuse stellate cratic precipitates, as we all know, the cratic precipitates are mostly fine and distributed in the Ehrlich's triangle, in the triangular area in the cornea. But sometimes when you examine the patient, you see the cratic precipitates extending up to the upper part of the cornea. So we call it diffuse kipes. And the viral cases have a characteristic feature, which is stellate kipes, like a star, but the ordinary kipes are rounded. As we all know, the viral cause trabeculitis and causes elevation of the intraocular pressure. And most of the viruses are dormant in the ciliary nerves. And as we all know, the innervation of the iris is sectoral, so you are expected to see iris changes. So this makes sense. So again, if I have unilateral anterior uveitis with diffuse stellate kipes with elevated intraocular pressure and iris changes, I suspect viral etiology. Of course, you may not have all these four, but sometimes you have diffuse stellate kipes with iris patches. You have diffuse stellate kipes with elevated intraocular pressure only. You cannot have all four criteria. On the other hand, the B27 disease is most common in male patients, middle-aged, and with history, the majority give history of low back pain, sometimes with psoriasis or inflammatory bowel disease. That's why I mentioned about the importance of the history. I hope I answered your question, Dr. Amr.
As a continuation for this question, how I will treat patient with viral uveitis?
Okay. Very
Yes.
nice. Very nice, Dr. Am. We have the most common viruses in our practice. They are the herpes groups of viruses and the rubella. The herpes group involves herpes simplex, herpes zoster, and cytomegalovirus. Rubella, to start with, doesn't have a specific treatment. Okay, rubella virus we don't have. But herpes simplex and herpes zoster respond better to acyclovir and valacyclovir, but cytomegalovirus responds to valganciclovir. So it is very important first to try to differentiate between herpes simplex, herpes zoster, anterior uveitis, and cytomegalovirus anterior uveitis, because the treatment is different. So, for example, the most common is the herpetic anterior uveitis, whether it is zoster or simplex. We give topical therapy, which is ganciclovir, which is the only available topical therapy here in Egypt. And the ganciclovir is efficient in both cytomegalovirus and herpes simplex and zoster. Regarding the oral therapy, as we mentioned, if I have a patient with herpes simplex, I give acyclovir tablet 400 milligram 5 times per day for 2 weeks. If it is herpes zoster, I give double dose 800 milligram 5 times per day. And of course, if you have elevated intraocular pressure, you have to give glaucoma treatment or IOP lowering medications. And of course, you can give steroids, topical steroids also, because topical steroids help the uveitis and also decrease the intraocular pressure by treating the trabeculitis. If you have cytomegalovirus, you can give ganciclovir, as I mentioned, topical. It will help. But systemically, unfortunately, we don't have the valganciclovir here in Egypt. It is called Valcite, but it is very expensive. You give it 450 milligram twice daily for 2 weeks, but it's very expensive. The bottle may cost like 20,000 plus. So just to recap, if I have the common herpetic uveitis, I give topical ganciclovir, topical steroid, topical IOP lowering medication, and systemic acyclovir.
Very good answer, Dr. Samir. Another question from one of our colleagues, which is hydroxychloroquine treatment. How you suspect that hydroxychloroquine treatment in certain type of patient will lead to retinal side effects.
Okay, very good.
How to
Very good,
how to
Doctor.
predict how to predict and how to avoid.
Okay, this is a very huge topic, and I have both one publication addressing this, and I have a detailed talk about this. We may have some time later in the future we can discuss this. But to answer this question, our rheumatology colleagues prefer Plaquenil because it relatively has fewer side effects. But to go directly to the answer, if the patient takes 400 milligrams of Plaquenil daily for more than 5 years, he is more susceptible to Plaquenil toxicity or hydroxychloroquine toxicity. But the important thing is to prevent this, because if you reach the stage of toxic maculopathy, it is irreversible. So there are some risks also. So the first risk is the high dose. So I always advise my colleagues not to go above 200. If you take 200, the tablet, by the way, is 200 milligrams of Plaquenil. They usually prescribe 2 tablets per day. So I ask them to cut down the dose. But if the patient is using 400 for 5 years or more, he has a higher risk. The risk is increased if the patient has renal failure. The patient is increased if the patient is female taking tamoxifen for cancer breast, which is very common. And the risk also is increased if the patient has pre-existing maculopathy like age-related macular degeneration or diabetes. The important question, how to early detect this toxicity. Of course, when the patient reaches the bullseye maculopathy, it is irreversible, so you need some things to help you. We have the OCT of the macula. The OCT of the macula in cases of toxic maculopathy shows early disruption of the photoreceptor layer, and also we have the macular visual field, which is a visual field specifically designated for to test the macula. These 2 tests, so I order visual field testing 10-2. As we know, when we order for the glaucoma, we order 24-2, and for the periphery 30-2, but for the Plaquenil we order 10-2 and OCT of the macula. And I have, in fact, diagnosed patient early with maculopathy, and I asked the rheumatologist to stop this medication. So when you have a patient with Plaquenil, you have to take a good history to know what is the dose and for how long, and if the patient has renal failure or a pre-existing macular disease. Yeah, unmute yourself, please, Dr. Amr.
Very good answer, Dr. Samir. I want to ask you another question of myself, which is the group of new topical steroid group, which is like difluprednate. Do you depend on these types of topical steroids in your treatment, and what are the advantages of these groups in treatment of uveitis in your experience and in your practice? As I mentioned, these drugs in the market, and the advertisement for it that it is effective. It doesn't elevate IOP much like the topical steroids. So I want to know from you experience what is the truth about this group of drugs.
Very important question again, Dr. Amr. I have no financial interests, but I don't recommend because these medications needs very careful use and monitoring. Difluprednate increases the intraocular pressure, and I have seen several cases using this medication, and they have elevated intraocular pressure, particularly if it is used more than 4 times a day. The pharmaceutical companies are always telling that don't exceed 4 times. And this is true. When you put it more than 4 times, you have elevated intraocular pressure. But the uveitis patients are very susceptible to elevation of intraocular pressure. So I don't prefer at all this group of medications. I always prefer prednisolone acetate 1% because it is the best. and penetrates the cornea better. So I keep away totally from this product, and but to be honest, I use it with patients with uveitis with a low IOP and hypotony because it can help me. But routinely, I don't use this, and I always advise my colleagues, whatever the brand, please use prednisolone acetate 1%. Don't even use dexamethasone. Dexamethasone, uveitis experts don't use dexamethasone in treatment of uveitis. We use prednisolone acetate 1%.
One of the questions from our colleagues, for how long to use systemic antiviral in case of uveitis?
Okay, also very important question. I will tell you my practice. I use them for 2 months, depending on the severity. Sorry, for 2 weeks. I'm sorry. I use them for 2 weeks routinely, but sometimes if the infection is severe and not resolving, you use full dose till 4 weeks. Okay, but if you have a recurrence, and this is the usual in the cases of herpes, you have to give a prophylactic antiviral therapy. As we mentioned, if you have, for example, herpes simplex, you give patient acyclovir 400 milligram 5 times per day for 2 weeks, and then you have to keep the patient on a twice daily dose for 1 year. But I myself also don't like this because this is the textbook and this is the science, the true science. But sometimes these drugs may affect the patient kidneys or affect the general health of the patient. So I try to taper them. Sometimes I keep the patient for 2 tablets for 1 month, then I give him 1 tablet. And I have patients, I keep them on 2 tablets per week. And I have published a case report on this. A patient with cytomegalovirus that I kept her on Valsite prophylaxis only twice per week. So it needs your clinical judgment. But if you are speaking scientifically, you have to keep your patient on 2 tablets per day, either 400 milligram it is for herpes simplex or 800 milligram if it is for herpes zoster for 1 year.
Another question from Taha Lutfi, Dr. Taha Lutfi. The question is, all KBs are anti-uveitis, so can pneumolar keratitis misleading as anti-uveitis? As I understand from the question, our colleague asking about that and sometimes KBs can be mistaken for some conditions like pneumolar keratitis.
Okay.
So he is asking how to differentiate between these conditions.
So by definition, or just about what you mentioned, pneumolar keratitis is inflammation in the cornea, in the substance of the cornea itself. But the keratic precipitates are precipitates of white blood cells on the back of the cornea. So you have to make a very careful slit lamp examination to determine the level of the lesion. Okay, sometimes it is confusing, I agree, but the KPs are KPs, which are just precipitates on the back of the cornea. But pneumolar keratitis happens with herpes simplex in the stroma of the cornea. Sometimes it is in the posterior part of the cornea, but it takes different shapes. But the KPs, as we will have a separate lecture on this in the future, inshallah, as Dr. Amr mentioned, the KPs can be fine, can be diffuse, can be stellate, can be maton fat, can be granulomatous, grazy, blah, 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 all of this. But the pneumolar keratitis itself, it is different. But I'm not sure you are talking about the Krushmer spots, for example, that we see in adenoviral. Sometimes they are confusing, but these are circular spots. These are totally different from the uveitis, and most of the adenoviral cases have associated conjunctivitis, but they don't have uveitis. They are very rarely the adenovirus with Krushmer spots on the back of the cornea or in the stroma. They are totally different. So just my advice is to have just a very careful magnified view of the cornea and to determine the level of your lesion.
Thank you, Dr. Samir. Another question, which is if you face a patient with inactive chronic non-granulomatous anti-uveitis, should you investigate it?
Very good question. So if the patient is stable with a good vision and good intraocular pressure, I will keep watching the patient. Okay, these patients from my practice, they have their own records and they have seen several doctors and they have previous investigations and labs. If I'm happy with them and satisfied, I will not order any other investigation. Because really, sometimes you accidentally see a patient with posterior synechia and ghost KBs, but he doesn't have active uveitis. So there is nothing to do for this patient, okay? Particularly if he's long-standing. So this patient, I ask him, please have a regular ophthalmic checkup, and I give him the warning symptoms. If you have photophobia, pain, blurring, burning, anything, please, you have to come. But I routinely don't ask for investigation. And this is important. If you remember from the lecture, the first important question, why do I order this test? I order the test to diagnose, to treat. So this patient, I will not treat. So you treat only
if you face a patient with signs of old uveitis, but it is not active.
Okay, Dr. Amr, this is the question, the very important question here to answer for how long the patient is inactive. For example, if the records, for example, from 2 months, and there is no specific diagnosis. In this case, I will also ask for investigations, as I mentioned before, to prevent further damage and to know if there is underlying etiology. But for example, I have patients like this coming to me. He tells me I have an attack of uveitis. The last attack was in 2013, for example. And he doesn't have any other attacks through this area. So the most common scenario is the disease was burned out. So in this scenario, I will not. So I don't have a good answer for this. This depends on the scenario and the history of the patient. In some cases, I order, and in other cases, I do not.
Another question from one of our colleagues asking about isolated inflammatory macular edema. Can we classify it as a possible cause or possible part of uveitis?
No. So what is meant by isolated inflammatory macular edema? There is, for me at least, I don't know this term. The macular edema is a complication of uveitis or a sequel of uveitis. It can happen with anterior uveitis. It can happen with posterior and intermediate uveitis. But macular edema itself is not a diagnosis of uveitis.
Finally, thank you, Dr. Samir, for this great opportunity for us for this nice lecture.
Thank you, Dr. Amr. It is always a pleasure to be with you and your colleagues and your audience. And thank you again for giving me this opportunity. And hopefully, inshallah, we can have several upcoming meetings, inshallah.
Thank you, Dr. Samir. Thank you.
Thank you. Goodbye. Thank you.
Assalamu alaikum wa
Wa alaikum assalam wa rahmatullahi wa barakatuh.